very good day to one and all. Today's topic is avulsion. So I'll be explaining a small brief introduction of avulsion will be there, consequences of avulsion, management of avulsion, based on at the site of injury, what are the management protocol we should follow, a brief description on storage medium, replantation, guidelines in management, splinting, antibiotics, endodontic considerations and follow-up procedures. So Anderson in 1972 has defined exarticulation. It is the other term for avulsion as complete displacement of tooth from its socket. So prevalence rate of avulsion in permanent teeth was found to be 1 to 16% and in primary teeth it was around 17 to 13%. And Lenstrup and Skiller in 1959 found out that the most commonly involved tooth for avulsion injuries are maxillary central incisors and seldom it was found to be lower anteriors. So the definition of avulsion given by American Association of Endodontists in 2003 was like this: as a complete separation of a tooth from its alveolus following a traumatic injury which results in extensive damage to the pulp and periodontal tissue. The most common etiologies which was found was fights, automobile accidents, sport injuries, domestic injuries, etc. So predominantly this avulsion injury was found in the age group of 7 to 10, and the most common reason for that is because in this age group the maxillary central, the periodontal ligaments, it was found to be loosely structured because around the erupting tooth the periodontal ligament was found to be loosely structured because it will be an immature tooth. 0.5 to 16% of the traumatic injuries are found to be more common in the anterior teeth. And the prognosis of all these avulsed tooth depends on management at the site of injury and also the extra alveolar time or the extra alveolar dry time. So all these avulsed tooth are basically tend to preserve or re-implant. The most common reason or the importance of preserving the tooth and replantation is to maintain the integrity of arch and establishment of the occlusion, and it also acts as an interim measure. It preserves the alveolar bone height. IADT in 2012 has classified avulsed tooth into three. That is, there is a clinical classification which was given by IADT in 2012 based on the viability of the PDL cells. So the three categories are avulsed tooth with viable PDL cells, avulsed tooth with viable but compromised PDL cells, and avulsed tooth with non-viable PDL cells. So based on this classification only, they has come up with the management of the avulsed tooth based on the PDL cell viability. So what is the consequence of tooth avulsion? What happens once when a tooth gets avulsed? So here basically what happens in the avulsion is when a trauma occurs, there will be extrusive forces impinging on the tooth. And because of this, there will be rupture of the periodontal ligaments, and even the remnants of these ruptured periodontal ligaments will be found in the root and socket wall. So pulpal blood vessels are severed and cessation of the blood supply to the pulp will get stashed. Like there will be stoppage of this blood flow or the continuation of this blood vessels towards the tooth will be severed. And the healing is basically dependent on to the extra alveolar time and the handling of the tooth. This extra alveolar time means the time when once like the time which it elapses when the tooth is outside the socket. So what is the dry time or how much time did the tooth was onto the dry surface, or was it in any kind of a medium, or all this dependent. It is that is what we call it as the extra alveolar time, how long the tooth has been out from the socket. So basically here attachment, damage and pulp necrosis happens. There will be tearing of the PDL which leaves the viable PDL cells on most of the root surface. So most of the PDL cells, viable cells will be onto the root surface. And the blood vessels also get severed. There will be cessation of blood supply to the pulp. And small localized cemental damage might also occur due to this trauma or the force which is impinged onto the tooth. PDL left attached to the root surface does not dry out. The consequence of tooth avulsion will be minimal. So if the PDL viable or the remnant PDL cells are not dried out, means the prognosis will be much better. Then excessive drying which will lead to the damaging of PDL periodontal ligament cells. So in turn, if the PDL cells are dry and damaged, severe inflammatory response will happen over a diffused area onto the root surface. So because of this inflammatory response, the prognosis will be much lower when compared to that of the viable, much lower when compared to normal viable PDL cells are maintained or preserved. So here osseous replacement or replacement resorption happens in case if there is any severe inflammation present after the reimplantation of the avulsed tooth. So there are certain periodontal reaction which happens when an avulsed tooth is reimplanted. So after reimplantation, coagulum will happen like occur between the two parts of the severed PDL. So on the tooth surface and onto the root wall or the socket wall. So line of separation often is in the middle of the PDL cells. It is found that mostly when a tooth is avulsed, the line of separation of this PDL was found to be in the middle. So proliferation in normally it happens for around 3 to 4 days, and PDL obliteration by young connective tissue. So PDL obliteration happens in a young connective tissue. So epithelial reattached at the CEJ by 1 week. So at the cemento-enamel junction, the epithelial reattachment will happen for around 1 week, and the gingival fibers will be repaired infrabony fibers later. So first the gingival fibers will get repaired during the healing process, and later only this infrabony fibers will get repaired. So after 2 weeks, the separation line in the PDL, so which we have discussed earlier, mostly it is in the middle third, middle portion. So by 2 weeks, this separation line will get healed, and resorption activity starts along the root surface. There will be initially a small resorption activity, but later on, as you follow up the procedure, you will see that this resorption activity will slowly heal. So healing with normal PDL, that is the normal reaction which it happens with a good prognosis. So here what happens is there will be complete repair of the periodontal ligament cells. There will be superficial resorption lacunae repaired by new cementum. So this is what you call it as the surface resorption. So here the surface resorption is found to be very normal. So in this condition, it is self-limiting. Spontaneous repair with the new cementum formation will happen. Resorption lacunae will be confined only to the cementum. So it won't. So here in this picture, you can see this is what we call it as resorption lacunae. So here this will extend, it will be confined only to the cementum. So it won't go beyond the cementum or to the dentin. So original outline of the root not restored initially. So radiographically, a normal PDL space around the tooth will be seen. Small size, the resorption lacunae will not be revealed when you take a radiograph. So here it is revealed. That means it's gone beyond an extent. So in a normal condition, you won't see the resorption lacunae as clear as you can see in this radiograph. So clinically, when you look into the oral cavity, if you see the position and the palpate and see, you will see that it will be in a normal tooth position. Normal percussion sound will be heard. So that is the normal healing pattern. Whereas healing with ankylosis is, here what happens is one phenomenon which is known as the replacement resorption happens here. So 2 weeks after replantation, fusion of the alveolar bone and the root surface happens. So once this fusion of the alveolar bone and root surface, so here you can see we won't be able to distinguish between bone and the tooth surface. So here it is clearly seen that there is alveolar bone and the root surface fused. So in such condition, we call it as healing with ankylosis. That means this tooth got ankylosed. So absence of vital PDL cover on the root surface. You can see there is no PDL space here. This might be transient or it might become permanent also. So what happens here is damaged PDL repopulated by the adjacent bone marrow cells, which has got osteogenic potential, which will lead to the ankylosis. So there will be progressive replacement resorption. So once the resorption starts, there will be replacement of this osteoclastic cells to the with the odontoclastic cells. Like the bone forming cells will get replaced at this place, and the tooth will get replaced by the bone forming cells. So this might be transient also. Transient means for a very small time. A transient replacement resorption might happen in minor areas of damage onto the root surface, whereas normal remodeling cycle of the bone, tooth becomes a part of it and root gradually gets replaced by the bone. That is what it happens in a ankylosed condition. So resorption intensifies along root canal fillings and tunneling resorption. This is where you can see most of the conditions. Here tunneling resorption happens and when it gets replaced. So first you will be able to recognize radiographically only after 2 months. So originates in the, so initially this reaction happens in the apical third, and you will see that there is no radiolucency in the resorption areas. And clinically what you can see is it will be immobile. It will be firm, immobile, and frequently in intraposition. That means the tooth, when you look into the adjacent tooth, this tooth will be intraposition or a little submerged condition. So on a percussion test, you will find a higher metallic tone. High tone will be there when you percuss and see. And in a transient type case, ankylosis disappears. Like when you keep on keep a proper follow-up, and after a year, you will see that the ankylosis will disappear. Here, the percussion sound returns to normal in such conditions. So here you can see initially, once after the replantation, the replacement of the tooth with the bone might have happened, and here by then tooth is ankylosed. So here in this pictorial diagram you can see initially resorption lacunae will be there, but the bone forming cells will get replaced. The tooth from the tooth surface, the bone will get replaced to that area. And finally, you won't be able to distinguish between which is the tooth and which is bone. So next healing process is by inflammatory resorption. So here, as you can see in this picture, there will be bowel-shaped areas of resorption of cementum and tendon. So there will be granulation tissues, especially the lymphocytes, PMNL cells, and plasma cells are the one which will lead to the intense resorption of these tooth surface. It starts similar to the surface resorption. So initially, it will start as a normal reaction. The resorption lacunae will be formed. So, but if the resorption activity is deep and pulpal canal is infected, then we can confirm it as inflammatory resorption. So what happens is in case if there is any like from pulpal necrosis, if the pulpal necrosis is present from this necrotic tissue is extremely susceptible to bacterial contamination. There will be a lot of load of bacteria in this necrotic tissue. So the revascularization of effective endodontic therapy is not carried out. What happens is the remnant necrotic tissue from this, the pulp space will be inevitably become infected. So the inside of the canal will be infected due to the remnants of this necrotic tissue. So bacteria in the root canal and cemental damage on the external surface of the root happens. So what happens is from this necrotic tissue, the bacteria will seep inside the dental tubules and will cause external inflammatory resorption. So here you can see from this necrotic tissue, initially there will be necrotic tissue. If you don't follow up with the endodontic procedure and if the canal is not properly cleaned, what happens is the remnants of the bacteria, the remnants of this necrotic tissue from there, bacteria will seep inside the dental tubules and if it reach the cementum, it will cause the inflammatory reaction. From there, the resorption lacunae will worsen, and because of the presence of this bacteria, this inflammatory resorption will worsen and will become bigger and bigger, and finally it will lead to the pulpal canal. So it is basically rapid. Entire root might get, there are cases where the root resorption had happened in few months, and frequent in replantation. It is basically 6 to 7 year old thin tendinal wall and wide tendinal tubules are the reason. So this inflammatory resorption cases are basically found in the age group 6 to 7 year old because the tooth, the whichever tooth has got avulsed has got the thin tendinal walls and wide tendinal tubules there. So there are more possibilities of the seepage of these microorganisms and the necrotic toxins within, and the inflammation will be faster than the normal condition. So simultaneously inflammatory and replacement resorption happens here. So in the radiographs, 2 weeks after replantation, you can see this kind of reaction in the apical third. So clinically, what you can see in such inflammatory resorption cases are the tooth will gradually become loose. That is, it will be mobile, it will become extruded. Not in ankylosis case, it will be intraposition, whereas in this case, the tooth will get extruded. And when you do the tendron percussion, or you will see a dull percussion sound. So this is the radiographic presentation. So after implantation of the tooth, you can see gradually after 2 weeks, 3, 4 weeks, the complete resorption will happen. Especially if the dentin is thin, means it will get faster. The resorption rate will be faster. So management of avulsion. So till now we were talking about the consequences and what are the reaction which happens to an avulsed tooth and how the healing of this replanted avulsed tooth happens. So coming to the management of the avulsion. So at the site of the injury, what are the things you should uh, consider at the site of the injury? First of all, keep the patient calm. Find the tooth and pick it up by the crown. Avoid touching the root surface. Avoid touching the root surface means there will be possibilities of this presence of this viable PDL cells. So you should not damage these viable PDL cells. That is why you should avoid touching the root surface. If the tooth is dirty, what you're supposed to do is wash it briefly for around 10 seconds under cold running water, and you should reposition it or replant to the socket. Try to encourage the patient or parent to replant the tooth. It's always better to replant at the site of the injury after washing it if it is dirty. So bite onto the handkerchief because at the site of the injury, we won't be able to stabilize this avulsed tooth. So in order to stabilize it, we can recommend asking the patient to bite gently onto a handkerchief to hold its position into the socket. So if that is not possible, what you're supposed to do is place the tooth in a suitable storage medium. Example, a glass of milk or in a saline or HPSS medium. If it is available, you can make use of HPSS medium. The tooth can also be transported in the mouth. So if nothing is available, you can keep it inside the mouth and between the cheek, between the molar and the inside of the cheek. Avoid storing it in the tap water because why we should avoid storing in tap water is because there will be more contamination. We doesn't know what is the contamination which is present in the tap water. So it is better to avoid keeping the avulsed tooth in a tap water. Seek emergency dental treatment immediately so that we can reduce the extraoral dry time. So guidelines of the clinician. So for a clinician, history is very important. So once the patient reaches to the clinic or to a hospital setup, establish whether the adult with the child has legal responsibility to validate or to see if the child has not underwent any child abuse or trauma, medical legal trauma, or we have to see whether the child, if the patient is a child, we have to see if the guardian or the parent, whoever has come with the child, has got legal responsibility. Determine what happened, including the mechanism of the injury, how the injury has happened, which have led to the avulsion of the tooth, and details such as height of the fall and the surface onto which the patient is fell. This can indicate associated injury. Example, facial fractures, head injuries, and you can suspect if there is any associated symptoms or other signs. Note the time of the injury. Replantation within 1 hour is associated with improved survival of the tooth. Explore whether and how the tooth has been stored. So how the tooth has been stored, that is also required because then only we will be able to go with the management of the or reimplantation procedure. Water and dry environment will definitely cause damage to the avulsed teeth. So ideally, milk is the better storage medium. So as you consult, be alert to the possibility of non-accidental injuries, including delayed presentation and inconsistent history. Pursue this as necessary because delayed presentation and inconsistent history will indicate a child abuse or child neglect. Physical abuse might be one of the reasons for this delayed presentation. Child abuse is one of the non-accidental injuries which we say. So on examination, examine the avulsed tooth. Is it complete or fractured? Is soft tissue injury evident, possibly indicating impaction of the tooth fragments? Or are other teeth damaged? Check the adjacent tooth also, lower teeth. And if no other injuries are suspected, a radiograph of the socket is not routinely advised. But in case if you suspect further injury, you can go with the radiograph. A chest radiograph is indicated when tooth fragments cannot be accounted. So in case the patient is unconscious or if you can't find out the remnants of this fractured tooth, then you can recommend them taking the chest radiograph. Examine the tooth socket. Has the tooth fractured and the root remains? This does not contraindicate in reimplantation. Is the surrounding bone mobile on palpation indicating fracture? So you have to see if the alveolar socket is injured, alveolar process itself is injured, and check for the jaw injury also fracture. So what you should do? Basically manage injuries of the greatest concern first. So that's the first line of treatment and provide analgesia as necessary. So only after giving analgesia only you will be able to get a cooperative child or you will be able to make the patient cooperative to whatever treatment you are providing. A tetanus booster is indicated if the tetanus status of the child is unclear and the tooth has been contaminated. So So if the tooth has been contaminated or check for the fall where the child has got this injury or where the child fell into, and based on that you have to check the status of the tetanus booster or tetanus vaccinations. Identify any soft tissue injury management can often be postponed until the avulsed tooth has been dealt with. So, coming to storage medium, what are the ideal requirements for a storage medium? How to select a storage medium? So, these are the ideal requirements you should look for a storage medium. If you are planning to keep a avulsed tooth, though that storage medium should have at least all one of these properties. Osmolarity in pH closer to the physiological condition. It should be readily available, longer shelf life, anti-inflammatory and antimicrobial properties, antioxidant property. It should be economical. Major factors which is considered for a storage medium is pH and its osmolarity. So according to Marino et al., it is closer to physiological state. So what is closer to physiological state? Here the osmolarity of that medium should be around 290 to 330 milliosmol per kilogram, and the pH ideally it should be 7.2 to 7.4. So why not a tap water? Tap water is considered to be as an unphysiological medium. So what happens is it causes rapid cell lysis because the tap water is hypotonic, unphysiologic pH is present, osmolarity is not physiologic, microbial contamination will be there. But in Ozin itself, Ozin in 2008 has proved that tap water is worse when compared to the saline. So it is a better interim storage medium. So if we have to carry the tooth and if the patient is unconscious, we won't be able to keep the tooth in the oral cavity also. When we are not getting saline, then in that condition, it's always better to carry the tooth in tap water than a dry storage. Saliva pH is around 6.3 and osmolarity is around 60 to 70, but still it's not having a proper osmolarity rate. But because of the easy availability, transportation better than dry storage, because of this condition, you can at least think of putting it in the saliva. Then there is saline. The most important or accepted storage media is your Hans balanced salt solution. So this was ideally proposed by John H. Hans, where the pH is around 7, ideal physiological osmolarity for around 270 to 290 milliosmol per liter, which is appropriate for the cell growth. It is non-toxic and contains essential nutrients. It maintains viability of the PDL cells for around 12 to 24 hours. So till 12 to 24 hours, we can keep this avulsed tooth in this medium. And it has got a shelf life for around 2 years. So milk is also found to be one of the best storage medium recommended by AAPD and IADT. The improved viability of the cells stored in milk may cause by physiological osmolarity of around 286 milliosmol per kilogram, and it has got a pH of around 6.7. And it was found that it has got cytoprotective effect of other nutrient constituent also present in the milk, which will help to maintain the viability of the PDL cells. The pH buffering system in which cell can survive is almost for 6 hours. It is less than HPSS, but still it can store for around 6 hours. So ideally, it was found that as so many researches have been conducted on milk, it is found that ice cold milk acted as more suitable storage medium than the normal temperature milk. So International Association of Dental Traumatology and AAPD says that milk is one of the third best transportation medium after wirespan and HPSS. Wirespan is actually a material which you will help to store this organ transplantation time and all organ transportation material is wirespan. Then there have been many studies on testing the viability of epithelial cells. They have done tests on propolis, the minimal essential medium, biospan. This is the organ transplantation medium. Then urocolins, egg white. It is proved that egg white is the best media for transplantation. Coconut water. Coconut water is also a good storage medium. There were so many other studies on saliva extract, GT, commercial green tea was also taken. Coming to replantation, it serves as a natural space maintenance. So replantation is very must because if you once you replant a tooth, it serves as a natural space maintainer whilst growth occurs and also enables alveolar height to be preserved. So traumatized incisors lost in early age, it is which has got insufficient alveolar bone available to support the implant processes. So in order to maintain that at least bone surface you can, it is always better to, even in future if you want to think about implants, that bone has to be preserved there. And the tooth can be maintained until the child reaches 16 years. Alveolar bone is preserved and simplifies implant replacement. So in case if there is any bone to place this implant, then there is no use. Then we'll have to think about the fixed partial dentures or removable partial dentures. For transplant reimplantation, the factors to be considered are avulsed tooth should not have any periodontal problem, reasonably intact socket should be there, reposition with the wards carver, then extraalveolar period has to be noted, then stage of root development, gingival laceration is sutured. Some of the contraindications for Some of the contraindications of replantation are the avulsed tooth has extensive caries and evidence of advanced periodontal diseases. So, in case of excessively dry or inappropriate storage, excessively dry means the patient or the whoever's guardian is coming, they might have like wrap this avulsed tooth in a paper or a tissue paper, and if they've taken more than 60 minutes to come and approach to a clinic or to a doctor, that means it is stored in a dry place. So excessively dry or inappropriate storage. The alveolar socket has major comminution of the fracture. If the socket is not intact, then also reimplantation can't be done. In case of uncooperative patients who does not maintain the oral hygiene, who cannot stabilize this replanted tooth and all, it is very difficult to get a good prognosis. Immature avulsed permanent tooth with very short root and wide open apex is also contraindicated. And other injuries are severe and require preferential emergency treatment or intensive care and compromised medical history. So in such conditions, replantation is not indicated. Zhu et al. In 2015 study aimed to investigate whether regeneration of periodontal ligament-like tissue could be promoted by stroma cells-derived factor and bone morphogenic protein, induced cell homing in delaying the implantation of the avulsed tooth. What they did was they tried to get these bone morphogenic proteins and stroma cell-derived factors, and then they tried to reimplant the tooth. So in order to see whether there is a regeneration of this periodontal ligament. If it is already a non-viable state, we can try to make it to regenerate these periodontal ligament cells. And it was found to be successful, but more studies has to be done onto the regeneration process of this periodontal ligament cells. So the decision tree for management of an avulsed permanent tooth. So this is one of the very important management tree which you should learn on avulsed permanent tooth. It is basically divided into immature tooth and mature tooth based on the apex diameter. So management of an avulsed permanent incisor with an open apex of around more than 1 millimeter. So more than 1 millimeter means it's an open apex case, immature tooth. So first, in every decision tree, this is based on APD guidelines. So, here you can, as you can see, initially assess the medical history, and if there is a neurological and non-dental injuries, you have to see that. Diagnostic tests has to be done. Rule out alveolar fractures. 3 radiographs angulated differently to rule out root fractures. Pulp vitality test, maxillary and mandibular angioplasties. Adjacent tooth has to be done in order to identify if there is any non-vitality or luxation injury, or if there is any other injuries associated with the adjacent tooth. So there have been 1, 2, 3, 4, 5 conditions they have discussed. So 5 conditions are immediately replanted case. Immediately from the site itself, the tooth has been replanted. The next condition is extraoral dry storage time less than 20 minutes, and tooth was transported in Hank's HBS solution or milk for 20 minutes to 6 hours. So here the dry time is very less, and even they have transported this medium into a physiological storage medium. In such conditions, what you're supposed to do is we are supposed to soak in a doxycycline or antibiotic solution for 5 minutes. Whereas the other situations are 20 to 60 minutes. If the tooth is kept moist in water, a non-physiological medium, for up to 20 to 60 minutes, then what you're supposed to do is you have to change the storage medium from a non-physiological medium to a physiological medium. For example, you have to transfer it into HBSS or cold milk. So other situation is 20 to 60 minutes extra oral dry time or storage time. So less than 60 minutes in a non-physiological medium or an extra oral dry storage time, you are supposed to transfer this into a physiological medium in HBSS or cold milk. And the other situation is more than 60 minutes extra oral dry time. More than 60 minutes dry. They have come late, especially they have not placed this avulsed tooth in a proper physiological storage medium. So all these conditions, apart from the immediate replantation, you are supposed to keep it in a physiological storage medium, then transfer it into an antibiotic solution for around 5 minutes. Whereas in a dry condition, what is supposed to do is debride with soft humus. This root surface has to be debride with soft humus. Prophylaxis has to be done. Pause or gentle scaling or the root planing should be done. Otherwise, you have to put it in 3% citric acid for 3 minutes and rinse well to remove the periodontal ligament. So all the dead cells has to be removed, because in case if there is any presence of dead cells, it will be a bacterial contamination, and this necrotic tissue will lead to inflammatory processes, reactions. So after that, what you're supposed to do is place it in 1.23% sodium fluoride, example APF, for around 5 to 20 minutes, so that this whatever hydroxyapatite was to this fluoride will get stabilize the tooth surface and will help to reduce the inflammatory processes. Then after replantation repositioning, what you are supposed to do is obtain periapical radiographs to verify the position. You have to verify whether the tooth, whatever replanted tooth, is in the correct position. Place a flexible splint for approximately 2 weeks, 4 weeks for dry time more than 60 minutes. So immediately replanted cases and with physiological storage medium, you can keep it for around 2 weeks, whereas more than 60 minutes extra dry time, we have to keep it around 4 weeks. And treatment procedure should include antibiotics, example doxycycline or penicillin 5, potassium for non-allergic patients for 7 days. Chlorhexidine rinse is indicated or prescribed for around 1 week. Assess the tetanus vaccination. If needed, get a booster within 48 hours. Provide post-operative instructions. Inform the prognosis. In case if it is more than 60 minutes dry time, you have to inform the prognosis that it might not be successful. And the follow-up has to be done in 7 to 10 days. So monitor every 4 weeks with a pulp test and even the radiogram. So ideal outcome, if you get an ideal outcome, revascularization or epixogenesis can occur over the next 12 to 18 months. And the alternative outcomes are initiate apexification with MDA or calcium hydroxide or root canal therapy if clinical or radiographic pathology is present. So in that condition, you have to keep a intracanal medicament. Consider decoronation procedure when clinical intrapositioning. Clinical intrapositioning indicates that the tooth is meant for an ankylosis. So in that condition, you have to do a procedure known as decoronation. Remove the crown part. That is what we call it as decoronation of the tooth. Or intraposition of the tooth, which will appear clinically and radiographically, which will indicate ankylosis. And the follow-up of all these conditions includes 1 week, 1 month, 3 months, 6 months, 12 months, and annually 5 years. Only after that you have to stop the recalling of the patient. So the next situation is management on a closed apex. Here the apex is less than 1 mm, that is a mature teeth. So here also assess the medical history and rule out any neurological non-dental injuries are there. Diagnostic tests has to be done, rule out alveolar fractures. 3 radiographs angulated differently to rule out the root fractures. Pulp vitality tests, maxillary and mandibular anteriors has to be done. So here also 5 situations are given. Immediate replantation, external dry storage time, less than 20 minutes, and which is transported in a physiological storage medium. Another situation if the tooth was kept moist in a non-physiological storage media, and the other condition is 20 to 60 minutes, less than 60 minutes extra dry time. So these two conditions, what you're supposed to do is we have to transfer it into a physiological storage medium. Only after that we have to think about the remaining procedures. And finally, more than 60 minutes extra oral dry. The dry time was more than 60 minutes. Here also we have to do the same procedure, debride with the soft humus. You have to remove all the dead cells gently to the scaling or root planing. Otherwise, you can dip this tooth into a 3% citric acid for 3 minutes and rinse well to remove the periodontal ligaments. After that, place it into 1.23% APF for around 5 to 20 minutes. So after that, replant it or reposition the tooth inside the socket. Obtain the periapical radiographs to verify the reimplanted tooth. Flexible splint, for example, approximately 2 weeks for a normal case and 4 weeks for dry time more than 60 minutes. And treatments like antibiotics has to be prescribed for 7 days. Chlorhexidine rinse will be indicated for 1 week. Assist the tetanus vaccination if needed. Get booster. Booster has to be taken within 48 hours. Provide post-operative instructions. Inform the prognosis based on the extraorbital dry time. Follow-up should be done within 7 to 10 days. So initiate pulpectomy or debridement on all teeth within 7 to 10 days. This is where it is important to remove the pulp tissue because in case if the pulp tissue is kept over there, this necrotic pulp will act as an or promote the inflammatory process. So after that, if root canal therapy was initiated, complete within 1 month, or if patient is not present until more than 2 weeks after trauma and a radiographic resorption is present, we have to think about pulpectomy, debridement as soon as possible. Long-term calcium hydroxide therapy, that is Tipex or calcium hydroxide place or slurry and change every 3 months, and this dressing has to be changed and check for the inflammatory reactions or if it's healing or not. Complete root canal therapy when periodontal ligament or lamina dura is observed healthy. After all these procedures, we have to do the follow-up around for 1 week, 1 month, 3 months, 6 months, 12 months, and annually for 5 years. So that's with the management of the avulsion. So both closed apex and open apex condition. So you should be knowing the question might come as the question management of an avulsed tooth in the age group of 6 or 7. In case of the 7, 6, 7, 8-year-old child, anterior tooth avulsion, you have to think that it is an open apex case. Whereas if the child's age is more than that, you have to think that root apex might have been closed. So you have to write the answer for management for closed apex case, where apical diameter is less than 1 millimeter. Another thing you should be knowing is anti-resorptive regenerative therapy, where local application of the glucocorticosteroids, cortico, cortico, glucocorticoids, and enamel matrix derivatives, and the systemic administration of the amoxicillin was used. So here, this anti-resorptive regenerative therapy might have the potential for enhancing the prognosis of the case with the PDL that is compromised, but not in a hopeless condition when compared to the calcium hydroxide. So, replantation of the primary teeth. So, one of the controversies which still exist is whether to replant the primary teeth or not. So, traumatology guidelines in 2012 indicates that replantation of avulsed primary teeth is not indicated. It's better to leave it around. But there have been cases where deciduous tooth has been reimplanted and it is found to be successful. So, absence of scientific evidence contradicting any primary tooth replantation was there, and there is no proper guidelines based on the arbitrary results and concepts. So, we can never say that we shouldn't or it is not contraindicated in replantation of the primary teeth when it gets avulsed. So, there is so many arguments against the replantation of the primary tooth because of all these things. Children have no aesthetic demand, so we need not replant the tooth. And the financial costs, time consumption, lack of children's cooperation, risk of pulp necrosis and external root resorption, and both primary and permanent, if infected pulp not removed, inflammatory resorption will definitely happen. So that has to be all these considerations had led to the not to reimplant the primary tooth in the socket once it gets avulsed. And it also says there some of the other reasons are replantation may inflict harm to the permanent successors because this forcing of coagulum to the developing follicle will happen if you reimplant the uh, primary tooth. Pulp necrosis will risk to the permanent tooth, but labally luxated tooth repositioning might happen if you forcefully reimplant the primary tooth. So there have been people saying that if after removing the coagulum, we can still try to reimplant the uh, deciduous tooth so that it won't damage the permanent tooth and all. But still, there have been no scientific evidence to prove that it is contraindicated or indicated, or perfect scientific evidence studies are not in the literature to support this. And there have been arguments to favor of the replantation also. Protocols for permanent teeth replantation was modified because conditions like it will definitely stand if tooth is gone too early. There will be problems with the speech. So the reimplantation is very important for the children because for the development of the speech, psychological impact, to reduce the psychological impact, development of the tongue thrusting. These are all conditions which will happen if there is an early loss of primary teeth. And some of the contraindications are systemic diseases, behavioral disorders, multiple avulsions, no adjacent tooth for splinting, avulsion of coronal fracture of the root with root fracture, severe fracture to the alveolar bone, then tooth close to the natural shedding, root resorption due to previous trauma, severely decayed tooth, teeth with infected teething prior to avulsion. So these are the conditions which is absolutely contraindicated in replantation of the primary tooth. So splinting onwards, we will be discussing in the next session. So thank you for the patient listening.